Is everything visible?
Yes, sir.
Yeah, it's there.
Okay, fine. I'll be talking about corneal cross-linking in thin corneas. So essentially, as you all know that today nobody waits for a keratoconus patient to be progressing and going on for keratoplasties, etc., or do a rehabilitation with contact lens only. Corneal cross-linking has become the treatment of choice, and it's a gold standard practiced all over the world. Now, as you all know that corneal cross-linking is the only treatment modality that is available till date which halts the progression of keratoconus and is a well-established modality, and it has also got FDA approval as things stand, and it is being practiced the world over. Now, what is important is that the standard Dresden protocol, what it says is that if you have to have the endothelium being safe, there needs to be, after the epi is off, a 400 microns that is required before you apply the corneal cross-linking. And this is above the damage threshold of the endothelium. So if you have 400 microns, the threshold from 0.18 goes to 0.3. So that is something very, very important that has been taken as I would say till couple of years ago as the Lakshman Rekha, which is there. But unfortunately, majority of the patients of keratoconus, specifically the ones who started keratoconus in the younger age, they come with thinner corneas. And in the Indian circumstances, as also in the Middle East, etc., the progression is found to be pretty fast. And the referral to centers where there is cross-linking is occurring at a later stage. I think even today, the optometrist or the optical shop still want to not lose the patient and continue to give contact lens rehabilitation to these patients and do not refer. Now, once you have these corneas which come to you in keratoconic patients where the corneal thickness is below 400 microns, there is the need to do corneal cross-linking in these cases, at least to try and retrieve the situation. So what does one do in such cases? Now, these are various treatment modalities which have been used over time, and I'll discuss them. This is the treatment modality of using hypotonic. Then you have transepithelial. So you have the Antophoresis, contact lens assisted, and lenticule assisted are the various modalities that have been described. Now, the first modality that was proposed way back in 2007 was by Hafizi et al. And they described the installation of hypotonic riboflavin. So you all know we started with Dextran, then went on to the HPMC, and then these are for the thin corneas where you have hypotonic riboflavin. So what you are doing is that because it is a hypotonic riboflavin, you are constantly putting drops. So there is an increase in the intraoperative time. This is you have to wait till such time that the cornea swells up. So actually you are inducing a swelling up of the cornea by using hypotonic riboflavin. Now the disadvantage of this is that the riboflavin that is going is of a relatively lower concentration of the collagen, and the stroma gets hydrated. Because the stroma gets hydrated, the collagen fibers become farther apart, and therefore the effect of cross-linking in the hypoosmolar riboflavin is less. Now, the next thing that came was that because what we said was that the endothelium needs to be 400 microns or more away from the focusing of the ultraviolet light. So therefore, the idea came that if we do not remove the epithelium, that means that the 60 microns to 65 microns that we have of the thickness of the epithelium, that is saved, and therefore the you are working on a thicker cornea as compared to an epi-off cornea. So this was called as a transepithelial cross-linking, in which there was no epithelial debridement that was done, and there were attempts to loosen the attachments of the epithelium by applying proparacaine eye drops every 5 minutes for 15 minutes, or by using BAC, or by using EDTA, etc., by which you could actually pre-soak the cornea, and by loosening the epithelial barriers, you would be able to have concentration. But again, the problem here was that the concentration of the riboflavin into the cornea was much lower, and therefore the transepithelial cross-linking did not give as good results. Now, the next thing that came was that if we are able to induce a permeation of the riboflavin by using electrical current, so that is called as antophoresis. which is a non-invasive technique in which a small electric current is applied to enhance an ionized drug's penetration through the intact epithelium. So this is what was thought to be good, and the major advantage that was touted was that it would spare the epithelium and would avoid the discomfort, could make it therefore an office procedure, and the infection etc. would be avoided because you are not going to have the epi off. But again, the problem here is that even though the riboflavin is negatively charged structure and has low molecular weight that is being used, the Antophoresis did not give excellent results. The procedure of Antophoresis is shown here, where an annular suction ring is applied. From here, you have an electric current that is applied, and 0.1% riboflavin, no dextran or sodium chloride, and addition of two enhancers, that is EDT and trometol, were put onto the riboflavin, and a constant current generator was given. And after this, because it was able to penetrate through the intact epithelium, you gave an irradiation of 10 milliwatts for 9 minutes. So that is what was done. Now, the initial study that was given by Vincigura et al., which was of 20 eyes, 12-month follow-up, there was a halting of the progression of the keratoconus and a significant improvement in the corrected distance vision acuity. Now, what was again looked at by other people was that the transepithelium cross-linking, the efficacy was controversial, as the penetration of riboflavin was again found to be deficient. So whether it was an epi-on procedure with paracane or whether it was a transepithelial with the Antophoresis, the penetration of riboflavin was less. And the other problem that is there is, which was highlighted subsequently, that when the epithelium is on, the epithelium takes away the oxygen availability. And as you all know that when you have to cross-link a cornea, the oxygen should be available. So if the epithelium has been scraped off, then the stroma does not take up that much of oxygen as much as the oxygen which is taken by the epithelium. So that was another reason why the effect was not found to be good in the transepithelium. And these are 23% of keratoconus cases in the transepithelial group continue to progress. This was Sotters et al. Who said, versus the epi-off. So epi-off, you had a much higher response that was there as compared to whether it is transepithelial with Antophoresis or transepithelial otherwise. Now, the next thing that came to increase the thickness of the cornea so that you have the endothelium that is away was described by Susan et al., Susan Jacob et al. From the Agarwal Eye Hospitals, and they used a soft contact lens. So you are using a soft contact lens to artificially increase the distance between the top of the cornea and the endothelium. But the problem was that the riboflavin could be trapped in the precorneal space. The absorption properties of a soft contact lens are obviously different from a stroma. And there is an inability to customize the thickness of the cross contact lens. So it's a standard 100 micron thickness of the contact lens which is there. And there is a buckling of the contact lens due to the procedure. So these are the disadvantages of the contact lens induced or contact lens assisted cross-linking. Now, we in our group have described a technique called as tailored stromal expansion by using a smile lenticule. So this is something that we have described, which has been published in the Journal of Cataract and Refractive Surgery in the year 2015. Now, what we do is that depending upon the thickness of the cornea of the keratoconic patient, that means supposing a keratoconic patient epi-off has 340 microns of corneal thickness. So you want it to be increased by 60 microns. So if you are having a patient of SMILE, which is say 4 diopters of refractive error, then the lenticule that you will be taking out, the central part of the lenticule that you take out in the SMILE would be approximately 60 microns. And you will place this lenticule onto the keratoconic cornea, and the thickest portion of the lenticule will be over the thinnest portion of the keratoconic cornea. So this is essentially the procedure that you have, where you remove the epithelium. So it is an epi-off procedure. You have a patient of SMILE. You can post these patients on the same day, or you can have a SMILE lenticule preserved also. You can preserve it in MK medium or whatever you want. And you have taken out this lenticule, and you are placing it on top of the recipient. So obviously you will have to do the tri-dot test in these patients and see that the patient is not transmitting any disease. So this is what you do. So you soak the lenticule, and you can see as also the endothelium, and you can see that we had a good penetration. After the cross-linking has been done, the lenticule, which sticks very well, is then removed, and then then after the cross-linking, you normally place the contact lens as is there. Now, we have shown excellent results in these cases. These were the results that were published, but we have since a long follow-up, and the first series that we did, the lowest corneal thickness that we had epi of was 326, 324 actually, and we got good results. There was no loss of the endothelium, and the demarcation lines that came were good. There was the stromal haze that you normally get after the cross-linking, which absorbed. And you can see that this is the contact, this is the cross-linking, the demarcation line that you can see that comes out pretty well in these cases. So the advantages of our technique are that this is a physiological increase in the thickness of the cornea. You are using stroma only to increase the stromal thickness. You can tailor make the expansion. So supposing I have a 10 diopter smile patient, so I will be having about 130 microns. So you can actually tailor make the stromal expansion, and you can augment it over the area where you want. There is a very firm adherence to the underlying cornea of the stroma. So therefore, there is no question of any buckling. There is no question of pooling of any riboflavin, etc. And you get a great outcome. Now, we have subsequently a 5-year follow-up. We have published of 3 cases of intracorneal ring segment implantation along with lenticle-assisted stromal augmentation for cross-linking in thin corneas in the American Journal of Ophthalmology. So this has been published recently as a case report in this year only. And what you have seen here is that these are the 3 cases, and they had extremely thin corneas. And you can see that pre-operatively, the keratometry is from 73.5 because we are using an intracorneal ring segment and a lenticule-assisted cross-linking. This has gone down to 65.7 from 55.4. It is 49 from 60.6. It has gone to 49.5. And you can see that the logmar best corrected visual acuity has improved significantly in all 3 cases. So it is a good technique even if you are doing it in advance. So we have advanced keratoconus. We are doing the intacts, but obviously the thickness in the paracentral region has to be sufficient for us to work with the intracorneal ring segments that is there. So this is a picture of the Visumax laser by which we do the intacts. We are making the channels, and we are putting in the intacts ring, and then we go ahead, put the lenticule, as you can see here. This is the lenticule. After putting the riboflavin, you continue to put riboflavin, and then you do the cross-linking. Now, to say as to what were the things that were being done, so there are 3 parts to it. One is you alter the stromal thickness. The second part is that you alter the riboflavin. And the third part, which was not worked upon till very recently, is that can you change the amount of UV radiation that is being given to the cornea in thin corneas. So when we are looking at stromal thickness, transepithelial cross-linking was done, contact lens assisted cross-linking was the second, and our technique of lenticule assisted cross-linking was the third. The hypotonic cross-linking, the hypotonic CXL was the use of riboflavin, which is hypotonic, to increase again the thickness of the cornea. But this new concept, which is gained ground, which is easily available with the Avedro machine, is what is known as an adapted fluence. So what they are saying now is that the total quantity of the fluence that you are giving onto the cornea is reduced. So this is the third part which is now being played out, which is the intensity of the UV light that is being given. So you are not working on the thickness of the cornea, you are not working on the riboflavin concentration, but you are working on the quantum of light that is being given onto the cornea in thin corneas. And this was reported by Hafizi et al. That biomechanical stiffening in porcine eyes, he showed in laboratory animal experiments, that low irradiance corneal cross-linking was there versus the standard Dresden. So if you are reducing the quantum in thin corneas, it is going to work. And this is, his nomograms are still being worked upon, which will be available. If you have a 400 micron, this is 300, this is 250. So what he's saying, instead of the standard 5.4 joules per centimeter square, he has used only 3 and 9 milliwatts. That is what he is using for the fluence. but he will reduce the total energy from 5.4 to a lower amount. So this exact amount is going to be out in the nomograms as to what it is. And this is another prospective monocenter interventional study, 62 eyes, where it has been shown that in thin corneas, here you can see that the demarcation line is coming here, where the quantum of light that is there has been reduced. Now, Cosimo et al. Has also shown that pachymetry based accelerated cross-linking. So instead of using the 3 and 9, they have used the accelerated cross-linking, and they have formed what is known as the M nomogram for standardized treatment of all thicknesses of progressive ectatic corneas. That means that depending upon the thickness, even if it is 200, 250, 200, etc. So this is the protocol they have made. And they have also used pulsed energy instead of a continuous in various places, and that is what they have shown, that by adapting the amount of fluence that you are giving on the cornea, you can work in thin cornea. So to sum up, what I will say is that no longer today 400 microns is the threshold for cross-linking. There are several innovative techniques that have allowed us to stabilize corneas, the cones of keratoconic corneas, which are less than 400 microns also. And as discussed, hypoosmolar riboflavin, contact lens assisted cross-linking, Antophoresis assisted cross-linking, epi-on cross-linking have shown some success, but the tailored stromal expansion is the most physiological, and our studies have shown that there is a significant reduction in the progress of the cone, and it works as good as a normal cross-linking would in thin corneas. And finally, I think what may come around, which can be easily used by everybody, would be adapted fluence in various machines that is going to be adapted. And once the nomograms are standardized, this is going to be the way forward. Thank you very much for your kind attention.